Welcome to our video on infections of the eyes and ears. Let's begin. In this lecture, we'll discuss otitis externa and otitis media. Let's start with otitis externa. Here's the overview slide of the topics we're going to discuss for otitis externa. Otitis externa, as the name implies, is an inflammation of the pinna and the outer ear canal. Before we go any further, let's recall the anatomy of the ear. The ear is divided into external ear, middle ear, and inner ear. The external ear consists of the pinna, also known as the auricle, and the external auditory canal. Otitis externa represents the inflammation of these structures. Let's talk about risk factors. Exposure to water predisposes to otitis externa because bacteria thriving in water can enter the ear canal and cause inflammation. This is why otitis externa is sometimes referred to as swimmer's ear. Trauma caused by cotton swabs or other objects in the ear can also introduce bacteria into the soft tissue of the outer ear. Foreign objects such as headphones or hearing aids can predispose to otitis externa. Finally, dermatologic conditions like contact dermatitis and eczema can disrupt the skin integrity of the outer ear, facilitating bacterial introduction into the deeper tissues. Otitis externa is most commonly a bacterial infection. If otitis externa is caused by exposure to water, then the most likely bacteria is Pseudomonas aeruginosa. On the other hand, if the outer ear infection is caused by any sort of ear trauma, then the most likely bacteria is Staphylococcus aureus. Otitis externa presents with fever, ear pain, also known as otalgia, ear discharge, also referred to as otorrhea, and pruritus. The ear pain worsens with auricle manipulation. This is in contrast to otitis media, which is characterized with the pain relief upon auricle manipulation. We'll discuss otitis media later on in this lecture. Additionally, otitis externa is accompanied by erythema and swelling of the external auditory canal. Here you see what otitis externa looks like. You can appreciate this erythematous and swollen pinna with exudate, indicating soft tissue infection and inflammation. The diagnosis of otitis externa is mostly clinical, based on the patient's history and physical exam findings. Otoscopy typically shows the swollen and erythematous external auditory canal. Importantly, the tympanic membrane is spared. Blood culture can also be done in cases of suspected sepsis. The management of otitis externa involves the topical fluoroquinolone drops, with or without topical corticosteroid drops. One may also consider earwick placement in order to facilitate medication delivery deep into the ear canal. Here is a table explaining this special type of otitis externa known as malignant or necrotizing otitis externa. The risk factors for the malignant otitis externa include age more than 60 years, ear irrigation for cerumen removal, and diabetes mellitus. Pseudomonas aeruginosa is the most commonly identified bacteria in patients with necrotizing otitis externa. The ear pain in case of malignant otitis externa is worse at night and with chewing. Additionally, patients may have the deficits of the facial, vagus, and accessory cranial nerves. The hallmark otoscopy finding in necrotizing otitis externa is the presence of granulation tissue in the external auditory canal. Management of necrotizing otitis externa involves IV fluoroquinolones like ciprofloxacin, with or without surgical debridement of the ear canal. This table summarizes the similarities and differences between the otitis externa and the malignant otitis externa. Please pause the video and take a moment to consider this table. Now let's review a question. A 65-year-old woman with long-standing diabetes mellitus presents to the physician with severe left-sided ear pain. She underwent ear irrigation for cerumen removal 3 days ago. The physical exam shows an erythematous and swollen pinna. The ear pain worsens with auricle manipulation. Otoscopy reveals swollen and narrowed external auditory canal along with granulation tissue formation. The patient is most concerned about her inability to move the left side of her face this morning. What is the best treatment option for this patient? This patient with long-standing diabetes mellitus presents to the physician with severe left-sided ear pain. Physical exam shows an erythematous and swollen pinna. The ear pain worsens with auricle manipulation. Otoscopy reveals swollen and narrowed external auditory canal along with the granulation tissue formation. All these findings are consistent with the diagnosis of malignant otitis externa. Malignant otitis externa is further suggested by the recent history of ear irrigation and the presence of Bell palsy, evidenced by the inability to move the left-sided facial muscles. The best treatment option for malignant otitis externa is IV fluoroquinolones, along with surgical debridement of the ear canal. We'll finish off the lecture by discussing otitis media. Here's an overview slide of the topics we're going to discuss for otitis media. Otitis media, as the name implies, is the inflammation of the tympanic membrane in the middle ear cavity. Let's briefly revisit this slide. The middle ear consists of the tympanic membrane and the middle ear cavity. Please note that the middle ear is connected to the nasopharynx through the eustachian tube. As mentioned previously, it is the inflammation of the tympanic membrane and the middle ear cavity that is called otitis media. Let's talk about the risk factors for otitis media. Acute otitis media is most prevalent in children from 6 months to 24 months. This is because children within this age range have shorter, wider, and more horizontal eustachian tubes compared to older children and adults. Therefore, the bacteria can easily ascend into the middle ear cavity through the eustachian tubes. Additionally, exposure to cigarette smoke causes ciliostasis in eustachian tubes. In other words, toxins in cigarette smoke stop ciliary movements. Therefore, cilia can no longer prevent bacteria ascending into the middle ear cavity. Finally, an upper respiratory infection can predispose the patient to otitis media. This is because the microbes in case of upper respiratory infection can spread from the nasopharynx to the middle ear cavity through eustachian tubes. The three most common bacteria causing otitis media are Streptococcus pneumonia, non-typable Haemophilus influenza, and Moraxella catarrhalis. Acute otitis media presents with fever and ear pain, also known as otalgia. Importantly, ear pain improves upon auricle manipulation. This is because the auricle manipulation straightens up the external auditory canal and relieves the pressure on the tympanic membrane. In contrast, auricle manipulation worsens the ear pain in case of otitis externa. The diagnosis of acute otitis media is mostly clinical, based on the patient's history and physical exam findings. Otoscopy typically shows a bulging tympanic membrane due to middle ear effusion behind the membrane. Importantly, the external auditory canal is spared. In other words, there is no erythema or swelling of the external auditory canal in patients with otitis media. This is in contrast to otitis externa, which is characterized by swollen and erythematous external auditory canal. Here you see the otoscopy image of the patient with an acute otitis media. Please note the bulging and erythematous tympanic membrane. There is middle ear effusion behind the tympanic membrane. Let's take a look at a question. A 12-month-old boy is brought to his physician by his mother due to inability and frequent crying. The child tugs on his left ear. He calms down when the physician pulls on his left pinna. Otoscopy reveals a bulging tympanic membrane. His mother reports 3 similar episodes within the last 6 months. What is the most likely reason for this patient's predisposition to the recurrent infections? This 12-month-old boy presents with left ear pain. He calms down when the physician pulls on his left pinna. Otoscopy reveals a bulging tympanic membrane. His mother reports 3 similar episodes within the last 6 months. The reason for frequent otitis media in children from 6 to 24 months of age is that they have wider, shorter, and more horizontal eustachian tubes. Therefore, it is easy for bacteria to ascend from the nasopharynx to the middle ear cavity, causing otitis media. Let's review the complications of acute otitis media. Acute otitis media can be complicated by conductive hearing loss because inflammation in the middle ear cavity can lead to sclerosis of the ossicles. Ossicular sclerosis limits the movement of these bones during sound transmission, resulting in conductive hearing loss. Additionally, bacteria can contiguously spread from the middle ear cavity to the meninges. This can cause meningitis or even temporal lobe encephalitis because the middle ear cavity is right below the temporal lobe of the brain. Finally, bacteria can contiguously spread from the middle ear cavity to the mastoid air cells, causing mastoiditis. Acute mastoiditis presents with swelling and erythema behind the ear. It is diagnosed with the CT scan that shows the hyperdense mastoid air cells consistent with pus. Mastoiditis is an emergent medical condition which should be promptly treated with IV antibiotics and mastoidectomy. Mastoidectomy is the surgical removal of mastoid bone. This is what mastoiditis looks like on the physical exam. Please note the erythema and swelling right behind the ear consistent with inflammation of the mastoid air cells. This is an axial CT scan of the head showing acute mastoiditis on the right side. Please note that the mastoid air cells look wider on the right side of the CT scan than on the left. In other words, the mastoid air cells on the right side are hyperdense on CT due to ongoing inflammation and pus formation. Let's talk about the management of acute otitis media. The first-line antibiotic therapy is oral amoxicillin. If oral amoxicillin is unsuccessful, we can initiate oral amoxicillin clavulate. Penicillin allergen patients with acute otitis media can take azithromycin. Let's also briefly review the management of the recurrent otitis media. Recurrent otitis media is diagnosed when the patient has at least 3 episodes within 6 months or at least 4 episodes within a year. Recurrent otitis media is treated with tympanostomy tube placement. This surgical procedure places tubes through the tympanic membranes to drain the pus out of the middle ear. Now that we've reviewed the management of acute otitis media, let's conclude this lecture with a multiple choice question. A 3-year-old girl is brought to the physician by her parents due to left ear pain for the past 2 days. She finished taking amoxicillin 3 weeks ago for acute otitis media. Her vital signs are significant for a temperature of 38 degrees Celsius. The physical exam reveals a normal pinna and external auditory canal. Otoscopy shows a bulging erythematous tympanic membrane. The patient stops crying upon auricular manipulation. Which of the following is the best treatment option for this patient? A. Oral amoxicillin. B. Oral amoxicillin clavulate. C. Oral azithromycin. Or D. Tympanostomy tube placement. This patient presents with left ear pain for the past 2 days. She finished taking amoxicillin 3 weeks ago for acute otitis media. She is febrile with a temperature of 38 degrees Celsius. Otoscopy shows a bulging erythematous tympanic membrane. The patient stops crying upon auricular manipulation. All these findings point toward the diagnosis of recurrent otitis media. Since this patient has already taken amoxicillin, now she should take amoxicillin clavulanate for recurrent infection. Therefore, the correct answer is option B. Here's a slide reminding us of the management of acute otitis media. Let's discuss why other options are incorrect. Option A is incorrect because oral amoxicillin is the first-line medication for acute otitis media and is given during the first episode. In contrast, this patient has a second episode of otitis media. Option C is incorrect because azithromycin is used to treat acute otitis media in penicillin allergen patients. This patient has no history of penicillin allergy. Finally, option D is incorrect because tympanostomy 2 placement is considered if the patient has had at least 3 episodes of otitis media in 6 months or at least 4 episodes in a year. And that concludes our lecture on otitis externa and otitis media.